late, so I'm going to speed through the first part of my presentation and then slow down slightly towards the end. And I took author's license here and changed the title a bit because what we're really talking about is small bowel bleeding. So I'll give you an overview of how we manage small bowel bleeding in 2019, and then I'll focus a bit more on angios. These are my disclosures. So our learning objectives today is, of course, to understand the nature of the problem and also to understand the appropriate investigation and management strategy we have and current outcomes, and then subsequently to avoid mistakes, which we would like to do in clinical practice. Bleeding in the small bowel, the facts. It's split usually into overt or occult. When it's overt, it's manifesting as melena or even fresh bleeding, and it accounts for up to 10% of GI bleeding episodes, the vast majority of which, especially in the elderly, come from small intestinal vascular lesions, which are also known as angioectasias. And even in 2019, which is why the title of the presentation is quite relevant, it still poses formidable challenges with high transfusion requirements, repeated admissions, increased morbidity, decreased quality of life. These patients are still bouncing in and out of hospital, and of course this trails costs. So you'd ask me, when should I repeat an upper and lower GI endoscopy? Should I repeat them or not? Well, there are some studies that show that if you do repeat an upper GI endoscopy, you increase your yield by up to about 30%, and this is because of overlooked lesions. And if you repeat a gastroscopy, you'd find things that were missed or were within the reach of a standard gastroscope in up to 64%. So it's not to be sniffed at. Repeat a colonoscopy, depending on the preparation, you can increase your yield to up to about 6%. And what overlooked lesions do we see? Well, in the upper GI tract, of course, there's Cameron erosions around a large hiatal hernia. Some people mistake folds for fundic varices or miss them, and of course the usual like peptic ulcers, angios themselves, and Dieulafours. In the lower GI tract, angios are things that are often missed, especially in the right colon, and especially if you give things like pethidine, because interestingly pethidine changes the vascular tone of angioectasias and makes them a bit more invisible. So if you're hunting for angios in the right colon, use things like fentanyl, and of course cancers. So it all depends on quality. If you've got a good quality endoscopy before, you don't need to repeat it, but if you've got the slightest of doubt, do repeat it. And this is echoed in guidelines. And lots of guidelines. So back to the small bowel, what are we looking at? What is the commonest cause? So if you've got a younger patient, you have to think tumors first. And this is why the Japanese tend to do a CT first, especially in younger patients, to rule out tumors. And of course, then there are the vascular lesions and other things. In the elderly, up to 40% of bleeding occurs through angioectasias, which are these small intestinal vascular lesions we'll touch upon a bit later. And then, of course, you've got the rare. So until recently, the small bowel was a very, very challenging place for the endoscopists. This has all changed over the last decade, and I won't bore you with what you know already. So capsule is the Scout. Device-assisted enteroscopy, mainly double balloon, is the Typhoon. And you are allowed to apply therapy with that. So small bowel capsule has become the front line for most instances, unless, of course, you've got a low threshold, as we said, in the young patients to do cross-section imaging, and it's got a very high negative predictive value and a high sensitivity for picking up lesions. So it's a highly effective, but timing is critical. So if your patient has bled, do the capsule soon, especially if it is a big bleed, because the chance of missing things, especially if it's a Dieulafour, is high. And of course, it still can miss things, especially in the proximal bowel. With the new capsules, which pick up the frame rate as they speed along, this is less likely. So one of these capsules by Pilcam Medtronic picks up its frame rate as it picks up speed, so less risky, but still, you can still miss things. Double-headed capsules possibly also miss less things. And this is echoed in guidelines. Capsule is mainly the front line. But, of course, always consider your cross-section imaging, as I said, especially in younger patients. And there is an argument for going straight to device-assisted enteroscopy, especially if you've got a significant bleeding episode, because the yield is high. And, of course, capsule can miss things, especially if the vessels hide. So this is an example of a large gist which was in the small bowel. It was not visualized through the lumen because it lived outside the bowel but had its vascular structures within the bowel, so it bled intermittently. All right, high diagnostic concordance with device-assisted enteroscopy, and of course, DAE has the advantages of allowing hemostatic therapy. Consider cross-section imaging, as we said. They have a high concordance and also pick up things that are missed by capsule. And the CTA and the CTE are interchangeable terms because nowadays a CT angiography also contains mesenteric angiography. Radionuclide imaging is not used very often nowadays, although it's got a very high sensitivity and specificity and may detect very low bleeding rates. It's cumbersome, and we tend to use it only in patients who we're not sure about, who have intermittent bleeding episodes, because you label the dye and that stays in the body and you can monitor them over a period of days, and I've used this occasionally. What about angiography? Yes, and it's useful to embolize, especially in the torrential bleed before an operation, but of course it is invasive, so it's used only sparingly. Meckel scans are only useful in up to 50% of adults. So what about the algorithm for bleeding? So we talked about it already. We start off with a capsule in most instances, although a second look endoscopy is also quite useful at times. And of course, if you've got a torrential bleed, you go and either direct to DAE or potentially to a mesenteric angiogram. And of course, if it's positive, you apply the direct therapy. If it's occult, so less acute, of course, you're going to go down the gentler route, capsule always first, and if it's negative, you either wait or you perform further investigations. And interestingly here, we've got reference to medical therapy, which can help us to treat these refractory cases, and we'll talk about it in a minute. Case examples, of course, angioectasias, commonest cause of bleeding, especially in the elderly, and we treat them usually with argon plasma. We tend to coagulate them, or else, if they've got a pulse-style component, a clip is useful. But there are other causes of bleeding. I hope this video plays spontaneously. If it doesn't, well, it is playing. So jejunal diverticular are things that can actually cause big bleeds, and I've got a case here which we did a few months ago, whereby we found a large clot in a very large diverticulum. And there's a trick here. This is why I'm showing the video. So when you have such a large clot, when you remove it, there's a chance of you causing a big bleed. So rather than removing it with a snare or with a clip, first we tattoo here just to mark it, and then we're going to use the clip itself to actually remove the clot. So you've got your tool ready at hand just in case this starts hosing blood. We also inject some adrenaline around it to reduce the risk of that being a big hoser. Tumors can bleed, and if you can't stop them bleeding, you can even tattoo for surgical resection, and this guy went for a surgical resection. This was a small bowel lymphangioma which was seen on capsule at first. Interesting images. You can see the congested villi with lymph within them, and then this was oozing away. There was not much we could do endoscopically, but we tattooed it. And the next case, if the video allows me to skip, is also interesting. So this is what we saw intermittently in someone who was having blackouts. There was a history of vascular surgery, And when we went down at double balloon, because the CT scan was not entirely conclusive, we found something that shocked the life out of us. We saw this, and this is not a piece of food, ladies and gentlemen. That is an aortic graft staring at us in the face. So behind that is the aorta. So this was an aorto-jejunal fistula. Other vascular lesions which aren't talked about often include ectopic varices, small bowel varices, and we tend to treat these if the portal vein is already occluded by injecting them with cyanacrylate glue, and it proves to be quite effective, but we only use it if there's no radiological option, because you can blow out the portal vein. And this is a very large varix and anastomosis, which is where they usually occur, and we're injecting with cyanacrylate glue. This is what you see afterwards, and the outcomes were good. So for bleeding, what are the overall outcomes of enteroscopic therapy? Well, overall, they're quite good. This was one of the first papers published by Cafes from Australia, a friend of mine, and it showed that it reduces transfusion requirements in iron therapy. However, the literature, although echoes this with Andrea May's paper showing that transfusion requirements drop, there is a rebleed rate, as this study from France showed. But with our combined study with the Japanese from Jichi Medical University, Yamamoto's group, we found that even if they do rebleed, which they do, if you keep hitting them at double balloon, the rebleeding rate reduces, so it's worth doing. But back to my mandate of angioectasias. So what are angioectasias? The Japanese from Jichi, Professor Yano and Professor Yamamoto, characterize them a bit further. So this is their classification, which I would invite you to go and see. And this guides therapy, because if you've got a pulsatile lesion, the use of APC is going to be very limited. You run the risk of applying too much heat with perforation, and it won't work. So it guides you to clipping. So if you see pulsation, you have to clip. And this is an example of such a lesion, a 2B lesion, which was pulsatile. So we're going through here. It's very faint. It's like a Dulafoy. And as we're going to clip it, we strike the mucosa just next to it, but it just goes to show how much these lesions can actually bleed. So you've got pulsatile bleeding, and underwater you can see the pulsation. If you had to use gel immersion, which is another novelty coming from Jichi Medical University and Professor Yano, you'd see things better. So this is why a clip works better. But what are angioectasias, ladies and gentlemen? Well, they're actually abnormalities of the capillaries which for some reason proliferate. And if you had to look at them under the microscope, you see a mushroom of proliferative vessels. And the pathogenesis is not very well understood, and it also relates to stress, shear stresses, mechanical things, but more importantly to VGEF, the vascular growth and endothelial factor. And there are things that promote VEGF production. And these things include von Willebrand's disease, because von Willebrand's factor tends to promote VEGF production. Chronic renal failure can also have an effect on it. And in aortic stenosis, you get destruction of von Willebrand factor with small multimers, which give rise to not only the prevalence of angioectasias, but also them bleeding, because in von Willebrand's disease, you get platelet dysfunction. We also see this for some reason as we get older, and in connective tissue diseases such as systemic sclerosis. And the reason why I mention the pathogenesis is because those are the targets for any pharmacological therapy you may apply. And this is the only guideline relating to pharmacological therapy, which was published from a group in Napoli on behalf of SIGE, which is the Italian Society for Gastroenterology. And the summary really is that hormones don't really work. Thalidomide has some benefit if you're really stuck, but of course the adverse events can reduce its tolerance. So people get neuropathy, peripheral neuropathy, somnolence, fatigue, And somatostatin analogues is the next choice. However, they can be quite expensive, especially if you're using long-acting analogues, and they can give rise to gallstones and potentially splenic infarction. So it's not as rosy as we'd like it to be. These are summaries of the studies favoring the use of thalidomide, so there was significance, and also for octreotide. But these are small studies. You can see the numbers are very small, and most of them are really uncontrolled. There was another retrospective series from Sheffield recently which supports the use of lenalidomide, which is a long-acting analog of octreotide, albeit there are cost implications and also risk of adverse events. So where does it fit in the quagmire of angioectasias? So endoscopy is still first line. If you can go and cook them or apply diathermy or clipping, it's still the first line. If there's contraindications to endoscopy, of course you're going to use pharmacotherapy to try to avoid those transfusion requirements or reduce them. But it can also be combined with endoscopy in those refractory cases. And do not forget acquired von Willebrand deficiency, because missing that can actually reduce your therapeutic armamentarium. Replacing the factor can help. Mistakes. So incorrect definition, not referring to a tertiary center soon enough, overlooking lesions, overlooking the need to perform dedicated radiology, especially in young patients, missing tumors, delayed investigation, poor investigation strategy, not considering things like von Willebrands, poor mucosal visualization, inadequate reporting, especially in cases who have repeat therapy, and incorrect strategy at device-assisted enteroscopy, and relying on a false negative. You have to persevere. And I invite you to read our article which was published recently on mistakes in small bowel bleeding. So our messages are: small bowel capsule is still a very useful tool, but don't forget your cross-section imaging. Timing is critical. It is going to guide your therapy, and there might be some benefit from adding pharmacotherapy or even von Willebrand factor if you've diagnosed von Willebrand's disease. I'd like to thank my team. I'd like to invite you all to Endo 2020 in Rio de Janeiro, and after that ESG days, and of course come to our masterclass in September in London. It's a fantastic event. Thank you.